Hello, everybody. I am Dr. Obonwudofia, consultant at the Federal Neuropsychiatric Hospital. I'll be taking you through what we do in the Calabar Substance Treatment Program, and I will talk about treatment for substance addiction. I will discuss briefly on the background or rationale for treatment. Then I will discuss the treatment goals, and I will shed some light on the activities in our program before I conclude. So on the background, we'll be discussing emotional vulnerability in people with addiction disorders and the general population. Here we have emotional arousal as it plots against time. Let's start with the general population. For example, a person is going to walk and his emotional arousal is almost at less than 2. That's where it's starting. And on his way to work, he finds out that his tire is flat, and that's distressing. And that distress takes his emotional arousal up till about 4. And then at this point, he's able to fix his tire and he's heading back to work. You find out that his emotional arousal level comes down till about the default, about at 2. And he's late at work, but the emotional arousal is still around the baseline. While at work, his boss tells him that he's late, and the boss is quite rude to him, and the emotional arousal comes back up a bit, and the boss leaves him, and after some time, the emotional arousal comes down to the baseline, and it continues until the end. Now, the plot for people with addiction disorders, it starts the same way. At baseline, about 2, you find out that on their way to work, they have a flat tire, and it is stressing. And they have an exaggerated emotional arousal up till around 8, and they're able to manage and fix their tire. But then, despite the fact that the trigger is no more, the emotional arousal is still at 8 and it's not going down. They are distressed on their way to work. It's bothering them that they experience that. While at work, the boss is rude to them, could be verbally insultive, and they are emotionally distressed and aroused, and it keeps on climbing up, and that's how the rest of their day is ruined. Now that's the difference. So we find out that in the general population, they're able to have not so high emotional arousal from a trigger, and at the end of the emotional arousal, it comes back to the baseline, close to 0. For the population with addiction problems, you find an exaggerated response at a normal stimuli, and there is a delayed time it takes to come down to the baseline level. On the background, why can't this group of people control their emotions? Now, 2 factors have been indicated in chronic emotional dysregulation, that is the long-term inability to control emotions. The first factor is the genetic predisposition. You find out that these individuals, maybe their parents had anger problems, their father, their mother, so it's genetically or biologically related or directed, and there is nothing you can do about this. It's in your genes. The second factor is invalidating environment. You find out that a personal experience that is expressed either via behavior or words, they are ignored or seen as invalid. You're not allowed to express your pain. Maybe your parents will tell you, "Are you the only one that is feeling sad? Go and sit down, go and sleep." Or people your age, "You're a man, you should not be feeling sad or crying. Go away." That's number 1. Then number 2, there's oversimplification of problem solving. The next point is that emotional outbursts or expressions are met with punishments. And when these outbursts are escalated, you find out that there are erratic or sporadic reinforcements. A child is sad or crying in the mall and asking for a cake or a cookie. Father says, just ignores him. It gets a bit worse, and father now begins to spank him, and it now gets worse. He's shouting, he's loud, he's crying, making noise. You either pet him, you know what, just calm down, I'm going to buy you your cake. And so you find out that the genetic predisposition and a chronic invalidating environment play together pervasively from childhood till adulthood to cause chronic emotional dysregulation. People with substance addiction, borderline personality, and other addictive behaviors, you find that the commonality is emotional dysregulation and distress intolerance. They cannot regulate their emotions and they cannot handle distress as the general population would be. You will hear things like, I want to feel better now. I cannot handle the fact that my emotions are still up there and they're not coming down. I want to feel better now. And you hear things like, I need to escape from reality. It is unbearable. So the commonality is emotional dysregulation as a problem and distress intolerance too. The goals of Calabar drug treatment program is to help our clients achieve the clear mind. There are three states of mind when it comes to drug addiction. The first is the drug mind. Some call it the addict mind. This mindset is that I cannot stop using drugs no matter what I do. My entire life revolves around drugs. I don't have don't have any control. So this stage, everything, the mind, the emotions, the cognition, everything is about drugs. Now the next stage of mind is a clean mind. The person must have been admitted for 1 or 2 or 3 days or kept in a place that is free from drugs. And he now has the ability to reflect that I've passed through a lot, I've lost a lot of things, and being admitted in this place was all I needed to recover. Nothing can take me back to using drugs. Willpower is all I need. Now, normally, we don't really need much to move a patient from the drug mind to the clean mind. Just keeping him away from drugs for about 3-4 weeks is a long time for him to move on their own to the clean mind. But the clean mind is a prerequisite for relapse. Most patients just kept in abandonment or just kept there in a place without drugs will have a clean mind. Our therapy moves the patient from the clean mind to the clear mind. The clear mind says that it's a mindset that says that I know, I believe that I will relapse, so I'm taking precautions to prevent a relapse. Even if I relapse, I still have structures in place to ensure that I get back on track. So the therapy program focuses on getting the patient to hold on to and practice a clear mindset. So the programming activities involved around achieving the clear mindset. We take the patient through mindfulness. We take him through distress tolerance activities, and we take them through activities that foster emotional regulation and interpersonal effectiveness. So we practice mindfulness-based treatments. We involve object identification, breathing, relaxation exercises, mindfulness with regards mindful living in general, and mindfulness for relapse prevention. We also involve urge softening with regards mindfulness training and practice. Distress tolerance activities would still involve urge softening. The urge softening is not just limited to drug cravings. Urge softening for sensations, urge softening for urges, and urge softening for thoughts and emotions. The patient learns to cope with distress by the practice of urge softening. We also have personalized or individual coping methods that they learn and rehearse. Also within distress tolerance, they practice yoga, which could be Kundalini yoga or even Christian yoga. This is dependent on the patient's belief system. Emotional regulation, the patient is involved in behavioral experience aspects of cognitive behavioral therapy and REBT. There's also the practice of meditative exercises in group as well as individual sessions. Anger management sessions are also a must within emotional regulation. Lastly, interpersonal effectiveness, we teach communication skills and we focus on assertive communication as well as assertive communication regards drug refusal skills. Other activities involve the patient working in a group with other people and they see how they can navigate towards navigate through projects with the help of their team members or group members. The nature of drug addiction is chronic, remitting, and relapsing condition, meaning that the patients are not just treated for a duration. Though our program structure is 12 weeks, where majority of the weeks is inpatient, residential treatment, and then outpatient is the minority of the latter aspect of the program. Irrespective of having a 12-week structured program, after this, we still have engagement of the patients in certain roles where they offer services to the program. This indirectly keeps them within the program even after the duration of care. Now, we also practice cognitive behavioral therapy, dialectic behavioral therapy, where we're looking at not just 100% drug abstinence, but if after a conscious effort at drug abstinence and something happens, the patient will opt for harm reduction instead of full-blown relapse. Harm reduction will ensure that he's able to come back to the recovery pathway. We also teach skills training, communication skills, working in group, amongst other things. Then this is evidence-based. Our treatment is purely evidence-based. We have come to the end of this webinar or introduction to the Calabar drug treatment program. For comments, you can drop them in the discussion group. For questions, you can reach out to me at Federal Neuropsychiatric Hospital Calabar, at our website, Twitter page or Facebook page. Thank you.